Good evening. I'd like to welcome everyone to the COVID-19 Vaccine Insights for the Pediatrician webinar on October 20th, 2021. My name is Donald Moore, and I'm with the Virginia Department of Health. I'll briefly cover a few administrative announcements before we begin. The discussion format for this webinar is 45 minutes of moderator-asked questions of panelists and 15 minutes of Q&A from attendees asked in chat, as all attendees are muted. Attendees who join by telephone who have questions should email their questions to eprtraining@vdh.virginia.gov. Your feedback is requested. Please complete the SurveyMonkey survey provided in chat. It will be emailed to all attendees as well. Also, this webinar has been approved for CME and CE credit. Those seeking credit will need to complete the same SurveyMonkey evaluation, which will ask you if you are seeking CME or CE. Please have your requests for CME or CE completed by close of business October 27th. This webinar is being recorded and will be available online. As required, because this is a CME approved event, there were no conflicts of interest to disclose from neither the planning committee members nor the panelists and moderator. Additionally, there is no commercial or in-kind support to report for this activity. Your panelists and moderator are as follows: Christy Gray, Director of Division of Immunization, Virginia Department of Health; Dr. Danny T.K. Avula, Virginia Vaccination Coordinator, Virginia Department of Health; Dr. Rebecca Leverson, Division Director, Pediatric Infectious Diseases, INOVA, L.J. Murphy Children's Hospital and Pediatric Specialists of Virginia. Your moderator is Dr. Michael Martin, President, Virginia Chapter, American Academy of Pediatrics. I'll now turn it over to Dr. Martin.
Good evening, everyone. Thank you, Donald. I really appreciate it. I'd like to start first by thanking everyone for being here, but more for those pediatricians out there for everything you've all been doing. I know the board and I are eternally grateful. Being in the same predicament that you are with the way things have been in the last couple of months, we know it's been difficult, and we're really appreciative of everything you have done. I'd also like to thank our partners at VDH for putting this town hall on and for sponsoring it, as well as our panelists for making the time to be here and answer our questions. The last thing I'd like to actually bring up just for you to know is on October 29th, Patrick O'Shea from the Framework Institute will be speaking on vaccine hesitancy. He was part of an ongoing project at National AAP sponsored, looking into vaccine hesitancy and how we as pediatricians can begin to address this both at a local level as well as a larger policy and larger scope. So put your save your date on that. That's October 29th at 12:15 p.m. Great. And on that note, we will get started. Again, I'll remind everyone to put your questions into the chat. I will do my very best in trying to get all of those answered as best I can from our panelists. So I'm going to start with Dr. Leverson. Just to kind of set the stage, we're on the verge of hopefully getting EAU for our pediatric population 5 to 11. If you can tell us a little bit about how the studies have been conducted and how that is different than what we've seen in the older kids and adults, and maybe even look at like some of the numbers of kids that we studied as well.
Sure. Thank you, Dr. Martin, for this opportunity. So we know a little bit of information thus far in regards to the Pfizer pediatric trials. We don't have the full information that has been submitted to the FDA, but that is not publicly available at this point in time. We would anticipate that we'll have much more of that information, the FDA briefing document and the Pfizer briefing document, hopefully by either the end of this week or I think the very latest would be Monday. But for the pediatric trial 5 to 11 and really 6 months to 11 years old, This trial started in late March, so March 24th of this year, and it was a phase 1, phase 2, phase 3 study. About 95 or 94 research sites, including 3 in Virginia, 1 in DC, 1 in Maryland, participated. 3 international sites also participated, and they had an estimated enrollment of about 8,000 kids. They've increased that enrollment a little bit more based on FDA's request. I think a little bit around 9,000 or so children from 6 months all the way to 11 years. But when we look at the 5 to 11-year-old population, they studied 2,200 kids, or almost 2,300 kids, 5 to less than 12 years of age. And what they did first is looking at what dose seemed to be effective. So they looked at 3 doses, the 30 microgram dose of the Pfizer messenger RNA vaccine, which is the adult dose and the dose that we use in 12 and above. They looked at a 20 microgram dose and then a 10 microgram dose, and they looked at a small population of children in that age bracket and then figured out what dose they were going to go forward with. And they decided that the 10 microgram dose was what they wanted to go forward with. Again, a 2-dose vaccine series, 21 days apart, and they randomized children in the clinical trial 2 to 1. So 2 got active Pfizer vaccine at that 10 microgram dose, and 1 got placebo, and they didn't know, who got what. And then what they did is they looked at antibodies, so that neutralizing antibody titer after the second dose in this population, and they compared that value on average compared to the older adolescent and young adult study, so the 16 to 25-year-old population. And they looked at that and said, gosh, these values were comparable, actually even better than the young adult study. And with that, that's called the immunobridging. So saying that if you make an antibody response, neutralizing antibody response, equal to or better than the young adult population, we know based on the young adult population, you are protected, 90+% from getting disease over X period of time. And so that's the setup of these pediatric studies. That was similarly done in the 12 to 15-year-old population. And then they also looked at some other markers. They were looking at how many of these kids developed asymptomatic infection based on having the nucleocapsid antibody present within the 6 months after that second dose. And so I imagine some of that is still ongoing, but from March to now, we've had, 6 months. And then also they looked for any confirmed COVID illness in this population who had who got the active vaccine. Again, the rate of infection was going to be estimated to not be high enough to really find significance in that, but that was another endpoint that they were looking at. What we know as to top level data is that children given the 10 microgram dose, 2 doses, 21 days apart in the 5 to 12-year-old or 5 to less than 12-year-old population made really nice antibody titers, those neutralizing antibody titers, comparable and actually better than that 16 to 25-year-old population. And so that's sort of in a nutshell, what they did. They have now rolled down to younger children, and they've looked down to 2 and also down to 6 months, with what we understand from press releases, consideration to have that data available for EUA potentially by sometime in the 4th quarter of this year. So hopefully in the next month or so.
I know one of the questions I've already seen kind of been posted is, what is the risk if the kids get a higher dose, if someone accidentally pulls the wrong vial and gives the higher dose? Is there a risk to kids? I don't know how much we know about that at this stage.
Yeah, so I don't think we have much data on that. We do have that small population of kids who did get that 30 microgram dose, who were between 5 and less than 12 years of age. So I think we can, garner a little bit of information from that. I've heard a lot of questions also about, well, what about if I have an 11 3/4-year-old? Do I give them the 12-year-old dose or do I give them the 11-year-old dose? I think one of the important things here is that 10 microgram dose, which is what Pfizer is submitting for, that was studied in adults, and everyone other than the elderly population in adults made a great response with that 10 microgram dose. So I have great comfort in saying, gosh, that 10 microgram dose is going to be perfectly fine. That may even be, fast forward to the future, that may even be the dose that we, de-escalate to, in the future for maybe a teen population or for others. We need study on that, and we need longitudinal study, but I don't have any qualms about that 10 microgram dose.
Okay. Thank you. Next, I'm going to actually bring in Christy Gray. Will the spacing of the vaccine in children be different? And I think Rebecca already hinted at it. And this has been floated in some of the circles I've been reading and seeing and the listserv. Is there an ideal spacing? So is there a spacing? I've heard that, while you can do it over 3 weeks, that there's a sweet spot that we should really aim for maybe later than 3 weeks. Can you comment a little bit on spacing?
I've not been told of a sweet spot yet for this particular series. But I can tell you that it's going to be recommended for 21 days. We expect it would still have the grace period like the 12 plus has, which means as little as 17 days in order to be valid. And when we are calculating whether somebody is late for their second dose or overdue, we look at 42 days. So I'll raise up the flagpole about whether there is a sweet spot, but that's the range between 23 and 42 we should be aiming for.
Great, thank you. I'm going to bring this up now because it's a question that was asked, and I think it's probably pertinent to this. If a person's, and we've had kids now, obviously a lot of kids who've had COVID infection, does that change any of the recommendations in terms of spacing? Should we be, there's some people bringing up the question whether or not we should space it further. And this doesn't have to just do with the 5 to 11, but for our older patients, if we're giving them the vaccine, should the spacing change if they have a history of COVID in the past?
Who do you want to start with that question?
I can jump in. And yeah, so I mean, the simple answer right now, Mike, is no. That the recommendation is still, even if you've had previous infection, that you complete a full series of the vaccine. Now, there have been a few small studies that have come out, at least when I was catching up on this last week. Nothing that I'd seen that had been fully peer reviewed yet, but a few small studies that showed in adults that the presence of previous infection and subsequent natural immunity can actually be significantly boosted by just one dose. And so I think, people are asking the question with a lot of legitimacy, and I think we'll see a lot more data evolve on this. And I wouldn't be surprised if recommendations down the road change, but as of now, based on the data we have, even if previously infected, the recommendation is to get the full series.
Okay, great. And Danny, since you're on the screen, a lot of us in the outpatient world, and we've talked about this with staff shortages, backlog of checkups. We're doing flu vaccine now. We're all giving a lot of flu vaccine. We're doing vaccine clinics and catch-up vaccines. We're working hard to get through all of that. And so there are people out there that are certainly hesitant to take on now COVID vaccine at the same time. I would love to hear, I think they need to hear from you and us, why should they take that on in addition to everything else they're doing right now?
Yeah, it is a good question. And let me first just say how grateful we are as public health for our frontline pediatricians, because you all have been amazing through the midst of this, providing guidance and support and navigating your patients through this. And now I know over the last couple of months, especially with school reentry, every pediatrician across the state is just completely slammed. And so know that we are hearing that feedback. And, Dr. Martin and I and Christy talk pretty regularly. And so even in our planning for the 5 to 11 rollout, really wanted to take that into consideration and have a sense of how much capacity there is in pediatric offices, and how much additional capacity we need to bring to communities, either through mass vaccination centers or contracted support. So please know that we have heard the concerns. I think to the question of, you know, what's the impetus or imperative for pediatricians to do this? One, you guys are where patients come, right? Like families want to come to their pediatrician to get their vaccinations. And so knowing that and being prepared for that, if there's a way for you to work that into your work streams, I think ultimately it serves kids and their families the best. No, and I'm sure you've heard this along the way, that the COVID vaccines can be administered with other vaccinations. So while so many of you are engaged in the work of helping kids catch up from this last 18 months, know that COVID vaccinations can be layered on right in the mix of that. Just give it in a different arm. I think from the kind of public health epidemiologic standpoint, two things that I would point, three things maybe. One, that, you know, as true as it is that kids are going to have much milder disease than our elderly and higher risk populations, this hasn't been harmless, right? In the last 18 months, we've had just under 1,000 pediatric hospitalizations and 10 pediatric deaths in the state of Virginia. And I think while you know, we're still learning what puts kids at higher risk for death, that reality, I think, really does tip the scales, the risk-benefit scale, towards vaccination. We know that kids, like every other communicable disease, are big spreaders. And so a big part of our public health imperative to get kids vaccinated is minimizing overall spread. So protecting kids, protecting community. And then there's a really practical, logistical element here, which is that right now the guidance around exposure is to pull out of school for a 10 or 14-day quarantine. And I know that all of you have heard how frustrating that has been for parents, how frustrating it has been for schools trying to figure out how to do this. And I do think the quicker that we can get to much higher vaccination rates in our pediatric population, the less disruption there will be to the school day. And so to keep kids in school, to prevent that learning loss, there's another really practical reason we'd push for it.
Yeah. And I'll say in Fairfax County, they did poll the parents just to see where do you want to get it. And by far way at the top is the pediatric office and their pediatrician. So I think it's important for people to know that, because I don't think that's unique to our area. And in many cases, they don't want to get it at other places. They really do want to get it in the pediatric office. So that may be our best shot. I'm going to swing a little bit to Christy, if I can. So this, I think, has been answered, but I want to make sure we answer this. Can vaccinators use the current 12+ vials to vaccinate younger kids if they adjust the dose? And a lot of people are, isn't it the same vaccine? And if it's not recommended, why? Oh, Christy, we can't hear you.
All right, thank you. These vaccines are not interchangeable with each other. Although they're the same vaccine, they're a different formulation. So the concentration is different between the two. So extracting out just a different dosage size is not going to give you the correct dose to give to the respective person. So they're not interchangeable in either direction. I know that we had provided a graphic comparing the two vaccines side by side. And if not, then Dr. Martin, I can send that to you later, and perhaps we can send that out. Oh, thanks so much, Susie. In the chat, you can see the link of this graphic. It's comparing, oh, perfect, thank you. So on the middle column, the purple top, this is the current formulation that is in use right now. in the field. And on the right, the orange top is a formulation that Pfizer is put forth to the FDA for emergency use for 5 to 11-year-olds. And they're doing this to try to distinguish between these types of vaccines. And it has a dosage, injection volume, the process in which you create the dilution, and everything you can see is different from each other. And then the storage conditions are also different. This vaccine is expected to be much more acceptable in primary care provider offices because it can be refrigerated up to 10 weeks as opposed to currently the 1 month time frame. It does skip the freezer completely. It'll be shipped in an ultra cold container and it goes directly into your fridge. It cannot be frozen based off of its formulation, and it cannot be interchanged with the other population. We are happy to provide this link out in the future, and we're sending it out to our COVID vaccine providers who are enrolled in Virginia so that they are aware of it as well. There's also upcoming Pfizer-led trainings that go through the entire, all this information in more detail. It goes through the actual packaging, how to expect the package to come in and what you need to do when you get the package. And so there's trainings that we're expecting to come in the next week or so that we will be providing on our website and our COVID vaccine provider newsletter so that you all can feel very confident in using this new vaccine.
Great. And if you can, I think it's important for people to know, just at least briefly, because there are people that have not started giving vaccine yet. How do they sign up to do that? Like, what are the basic steps? And I know you have a great website for that as well. And if they do that, if they sign up, are they obligated if things change suddenly, which we've all been experiencing on the ground? If they have a horrible week and there's a huge flu epidemic and they're like, whoa, we can't run this clinic at this, how are they able to sign up but not necessarily move forward?
Sure. So enrolling as a provider does not put you on a list where we push vaccines to you. You actually have to take the step to request the vaccines be sent to you. And then with this new pediatric vaccine series, if something happens where you have maybe 1 or 2 weeks where you have to cancel the appointment, you can't use it, you do have longer time frame to have that vaccine in your fridge before you have to use it. We also have a great program where you can notify us that, I thought I could use this, but I don't have the patient population, the demand isn't there, or I'm low staff, what have you, and we can redistribute that vaccine to another provider, and we help organize that here at Central Office at VDH. The website that's currently on the screen here, let's see here. Can you click home?
It's a screen capture, unfortunately.
Oh, okay, no problem. All right, so if you go to, let me see here how I can work through this.
Christy, I put the link in the chat.
Oh, perfect. Is there a way to click on that and share it?
Yes, I'll open it up now. Let's see here.
Okay.
Give me 1 second.
If I remember, Christy, so there's a few steps to this, right? So you have to sign up initially intent form. Is that still the same where you sign up for an intent provider form through VDH? And then the next step is the CDC, if I'm correct, agreement?
Yes, sorry, Dr. Martin. Yes, a provider intent form essentially says, yes, I'm interested. And then we contact you and say, okay, we register you in our site called VRIP. It stands for Virginia Electronic Registration for Immunization Programs. And you create an account in that, and we attach the CDC agreement into that account, and you complete it. We have PDF documents so that you can print it out, get all the information before you actually complete it. And that is a requirement by the CDC that you have to sign that agreement. It asks questions like, main point of contact, hours that you can receive vaccines, your shipping location, and then the ordering providers on site. You submit that CDC agreement. We make sure you're connected with the Virginia Immunization Information System. This is our state immunization registry. All doses of COVID vaccine that are administered in Virginia are required by the CDC to be reported to VIS, and that's how we report to CDC the doses that are being administered in Virginia. So we make sure that you're connected with VIS, you know how to use it either through the website or we connect it to your electronic medical record system. And then you get access to what's called VaxMax. And that is our vaccine ordering website where you can go in, submit your orders of which vaccine you want. And that's also where you can see the order's been shipped, get notification by email. And you can also see all the information we have about your location. How many vaccines have you ordered? How many have you administered? How many have you wasted? What's your current vaccine inventory on hand? That is also reported in Vaccine Finder. There are definitely several steps to this to make sure that there's communication and accountability of this vaccine throughout the entire process. Vaccine Finder, where you put in your information on your daily inventory, as well as your location information, you have the choice to make yourself a public located site, which means when somebody searches on vaccines.gov for a location to get vaccinated, you can choose whether you're visible or not. There are several sites that want to be visible, and there are sites that don't. So you have that choice to make yourself visible if you do want to bring in people that are maybe not necessarily your patients. But if you want to just vaccinate your patients, you have that choice to keep your location private and not viewable to the public.
Christy, is
Which
this
is
the
super
webpage you're referring to?
Yes, thank you. So on this website, and Susie had put the link in the chat, on the left-hand side, this enrollment process flow and checklist tells you everything I just said. It tells you everything in a little list of what you're going to need to do. And then on the right-hand side has the resources like that PDF document I mentioned of how to actually walk through the process. You might also have the redistribution documents. So as I mentioned before, maybe you have a situation where I don't need all this vaccine. I want to redistribute it to some other provider or back to VDH. This has information on how you can go about doing that. You're not on the hook. You don't have to keep it if you don't think you can use it. And then there's also information about should there be any wastage or a question about accountability in managing your vaccines. There's guidance here on that. Wastage can happen, especially with COVID vaccines, because they have to be administered in a certain period of time. And we want to avoid missed opportunities. So for example, if I have a 10-dose vial, I have 3 kids that are coming in, and I know I'm have 6 hours to administer this vaccine. It's the end of the day. I want to make sure I vaccinate those 3 kids, and I might have to waste the 7 remaining doses in that vial. It's better those 3 kids are vaccinated than to have the missed opportunity that they don't get vaccinated and you don't waste the vaccine. So, but we have lots of guidance on how you can schedule your processes to try to avoid waste as much as possible. And then we have reimbursement guidance on here as well. All COVID vaccines are purchased by the US government. They are free to everybody. No out-of-pocket expense, which means you can't charge for administration fee either. You can charge the insurance plan the admin fee, but you cannot charge the person. So you can't charge the insurance company and then go back and because the insurance company says no, and go back and bill the parent. You can't do that. There's no out-of-pocket cost for COVID vaccine.
Yeah, I think that's really important. So administration fee, and that's essentially what we can bill for. So there's some questions a little bit, I guess, more about getting into the distribution and when they do get this. I have heard different things. So will the distribution be coming like it was before from the local health departments, or will it be coming? I think I've seen some stuff indicating that it may come direct to the providers to expedite it coming out.
Yeah, so for the pediatric vaccine, we want that to go to medical homes. We want it to get into your offices as much as possible. So the route to do that, when you are an enrolled COVID vaccine provider, we can directly ship that vaccine to your office. If you need less doses than the minimum direct shipment for the initial vaccine rollout, which is the first week of this rollout, 300 doses is the minimum shipment. So if you can't move 300 doses, you have 10 weeks, right? In the fridge. Would be great if we can move it faster, but definitely before 10 weeks. Then you might need less doses. In that instance, a local health district can have the vaccine shipped to them. They will break it down and redistribute it to you. So depending on your situation, either one could happen.
Okay.
I do recommend that pediatricians, you're contacting your local health district and having that conversation about what would make most sense.
Okay. And once, I just want to remind folks, so once they have doses, how long will those keep? And also, like once you have mixed the vaccine vials, how long do you have to administer the doses?
Okay, so if you have an ultra cold freezer, 6 months. If you have if you're moving it right to the refrigerator, they are good for 10 weeks. Once you mix it and puncture it, same timeline there, 6 hours. And
Right,
we do know Pfizer also knows that is definitely a limiting factor.
Okay. No, that's good. And I guess, as part of this conversation, Danny, I know we've had conversations about where, one, I think it is going to be challenging for a lot of practices. They're going to have a huge number of patients that want it immediately, and providing them alternatives, since we likely in offices may not be able to give everyone that wants it that first week. Can you kind of start to talk to us about where families can go other than their pediatric office if they want an alternative place to go?
Yeah, absolutely. And I think Christy nailed it when she said our hope and our goal is really to prioritize those practices that want to be vaccinating. We recognize there's some practices that just are stretched thin and may not be able to now. And so, our initial strategy, we're getting about 252,000 doses this next week into the state of Virginia. And then on top of that, there will be probably about 125,000 doses that come through the federal retail pharmacy program. Now, remember, there are only 723,000 5 to 11-year-olds across the state of Virginia. And at least what the national survey data says is that really only a third of those are kind of ready right now to get vaccinated. So I really don't have any concerns about sort of the bum rush that we saw in January for vaccine, although we know that the demand will distribute differently, right? Some of you guys in Northern Virginia are going to see a lot more demand than us in Central Virginia or out in Southwest. And so, we want to take that into consideration as well. So we're really prioritizing pediatricians and family practice, outpatient medical homes. There'll be a pathway for pharmacies as well. And then to ensure that there's additional capacity in communities that need it, we are prepared for our community vaccination centers, those CVCs, to not only administer boosters, but also to administer vaccine to 5 to 11-year-olds. And then in addition to those pathways, we are also using FEMA dollars to contract with other types of vaccinators, other companies that will do what we call precision clinics. So we're working with the local health districts across the state to identify where is that additional capacity needed and where might we have a precision team work with a school, for example, and do school-based vaccination. In some parts of the state, local health departments are pairing up with schools and either doing in-school vaccination or after hours or weekends in school. So there's going to be some variability across the state, and we'll kind of take the uptake in the 12 to 15-year-old population as the marker of where we really need to prioritize doses for demand right now.
And for this information, how will, in different regions, how will people get this information out? Is there going to be a central source, or is it going to be through the local health departments, or is it a combination?
Yeah, it'll definitely be a combination. So we will push out at the state level, and there's also state level messaging really targeted to parents around the value proposition around this vaccine, why it's important for 5 to 11-year-olds to get vaccinated. And then the specifics of where will really be driven through vaccinate.virginia.gov. I mean, we recognize the vaccinate.gov site is not always the easiest to maneuver, especially when you're looking for a specific location. And so we've asked our partners in local health departments and in local communities to get that information out as well. So it'll be a multi-pronged approach where we are pushing out information from the state, but then locally, because it's going to look different in each locality or region, there'll be a more tailored approach there as well.
Okay. I just want to make sure I'm hearing correctly. Then for folks regionally, they should reach out to their health department for the most up-to-date guidance?
In terms of where to get vaccine? Yeah, absolutely. Because we are working centrally, we're working with the local districts to where are the community vaccination centers going to be, and if they are bringing precision clinics, where are those going to go? So I think it's very appropriate to reach out to the local health districts.
Okay, great. And we've got someone already asking my next question, which is the algorithm of when these initial doses come out, how is it going to be decided where doses go? I mean, I don't expect we're going to have everything everyone wants right away. And so how will prioritization work?
I'll take that, Christy, or you want me to?
Sure, I can start. So we are looking at the population of 5 to 11-year-olds by district, as well as a proxy of where 12 to 17-year-olds were vaccinated, to predict where this population may get vaccinated. We are, though, putting in the caveat that 5 to 11-year-olds aren't necessarily the same as 12 to 17, especially the younger side of that. And parents may tend to not necessarily take those children to where they took their 17-year-old. And so we're looking at district numbers, we're looking at uptake numbers, and combining those together to forecast where the percentage of where the vaccine should go. We are prioritizing putting these vaccines in the, as I mentioned before, the medical home channel, the practice channel, where private medical practices, also FQHCs, free clinics. And something that I hadn't mentioned before is that our pharmacies, which are actually been stellar in our COVID response and vaccinating the majority of people in Virginia as a channel, they are getting their own allotment through the Federal Retail Pharmacy Partnership Program, which is a federal allotment separate from our state allotment. So that's allowing us to really put more vaccine into the provider channel as opposed to the pharmacy channel. And we've been able to allocate more doses that way. Danny, anything else to add?
No, I think covered it. Thanks.
And I feel like we have to ask Dr. Leverson a question. So I'm going to bring Dr. Leverson back into this. And I think you answered it, but I want to make sure everyone hears. So we're vaccinating kids for flu. We're vaccinating all kinds of kids trying to catch up. Any restrictions on when we vaccinate, whether it's a live or not live viral vaccine, in relation to the COVID vaccine for the younger kids? And do we know that?
So ACIP recommendation for older children already, is that there's no specific time frame or really a 1-inch separation in the same arm. It could be in older children. We'll wait for ACIP on younger children because, again, a 5-year-old's arm may be smaller than a 16-year-old's arm, but we'll wait for that. In regards to studies that have actually been done looking at, do you see a decrease in vaccine, responsiveness from one versus the other? We don't really have that data. There's some early data coming out of the UK looking at flu vaccine in adults, and it looked fine. But we're really leveraging off all of the other data that we have on combination vaccines, saying this is fine. There's not going to be any concern. As I was taught in medical school, your immune system is quite robust. It is able to handle all of these different triggers coming toward it. And so I don't think that we should have any concerns about that. Get vaccines into arms.
Okay. And Christy, I'm going to kind of come back to you. Some of these, I've got a couple asking the same question. The wait times had been 15 minutes for most patients and 30 minutes if there was history of allergies. Is that going to be different with our younger crew, 5 to 11? Are there any different rules to that?
I've not heard that they would be different. We would expect to see that in the ACIP recommendations and the following clinical considerations that they publish. I don't have reason to think they would be different.
Okay. And following up with that, because part of the process, consent, anything different with consent that we'll be obtaining from patients' families?
I can't think of anything different with consent either. We've already been vaccinating 12 to 17-year-olds.
Okay. Does the parent have to be present?
So that's always a tricky question from VDH standpoint. Parent, guardian, or somebody standing in loco parentis. I don't want to speak to any policies that pediatricians may have, but that is policy from VDH standpoint.
Well played. Thank you. Let's move around a little bit. Dr. Leverson, so I mean, I think a lot of us are hopeful that vaccination is really going to change quarantining in schools and really change the dynamic and a lot of what we're struggling with contact tracing and having to be out of school for an extended period. Is masking still going to be necessary among vaccinated kids? And any other mitigation strategies that will change when you have a large number of kids vaccinated?
I think that's an excellent question and a hope for the future, but I don't think that we're there yet. I think, we need more real world data in regards to asymptomatic transmission and, other things like that. But I'm very hopeful that the modifications that we've had in quarantine after exposure will fall in line like we're seeing in the adolescents who are vaccinated. But to be able to get rid of masks in schools, I think is going to depend on a little bit more data and certainly uptake of vaccine.
Okay. I'm going to shift a little bit to adverse effects. And I know one of the big ones is obviously myocarditis is a major concern for a lot of us. Do we, with the so one question that came up is with the lower dose, do we anticipate lower, with a lower dose, will you see less myocarditis? Do we know that?
So we don't know that yet. Again, the kids who've been studied, really, we're looking at 2,200 kids, and we're looking at a max rate of myocarditis, myopericarditis in the Pfizer vaccinees of sort of a max rate of 1 in like 25,000 males, 12 to 15, 12 to 19, 12 to 29 years of age, sort of that general population. 12 to 29 would be 1 in 25,000 after a second dose. And so with that, you just don't have the numbers to be able to conclude anything. There hasn't been any report that's been publicly available from Pfizer yet that I've been able to find that speaks to was there a case of myocarditis or not in this trial with the younger kids. We'll see what next week brings. And the other question is, will a lower dose? I think that's a reasonable question, because if you look at the Moderna vaccine compared to the Pfizer vaccine, and those males 18 to upper 20s, you see a little higher rate. And again, Moderna is 100 microgram dose compared to a 30 microgram dose. And so there may be a signal there, but again, this is speculation. We really need to see, what these rates look like, what we call post-marketing, so after we see it. So I think that continued vigilance of if a child within a couple of days of vaccine develops, chest pain or shortness of breath, that they should be evaluated so that we'll really have information. I think in our area, we've seen maybe about 10 or so kids. Again, mild symptoms, give ibuprofen, we follow troponins. We'll see that, those all seem to resolve within about, 24 to 72 hours or so. What we really want to find out is, what do they look like at 90 days? What do they look like at 6 months in regards to, is there anything there? And so we're waiting for that data. CDC continues to follow these adolescents and young adults to see if there's any long-term problem or any long-term concern at all, or if everything goes away. So again, that's a question that we have, but I think I'm very hopeful that this lower dose will see a much lower rate.
Great, thank you. And Danny, I don't know if you have anything to add to this, and particularly, what should we be advising? Certainly the 12 plus, maybe what we'll be advising the younger kids in terms of because I think it's very helpful for us. Obviously, something we normally do if we know what to anticipate to keep parents feeling good about the vaccine.
Yeah, well, I certainly echo everything that Rebecca just laid out. I mean, and I agree with the sentiment that a lower dose will likely see less of that effect. I think there may be two ways that, as clinicians trying to reassure parents, two frames that are helpful. One is that what we've seen in that younger adolescent male population is about a 60 to 70 per million case rate of myocarditis, pericarditis. So just and to remember that COVID itself also causes myocarditis and pericarditis at a significantly higher rate, about 450 cases per million. So remembering kind of the relative risk of myocarditis associated with vaccine versus myocarditis associated with COVID itself. The other thing, when the original data review was done by the Advisory Committee on Immunization Practice, they mapped out in what I thought was a really helpful framing, where they said, if we were to fully vaccinate both doses, 1 million people, we would expect to see somewhere between 60 to 70 cases of myocarditis, but we would prevent about 11,000 cases of COVID, about 500 hospitalizations, about 120 ICU admissions, and then somewhere between 6 and 9 deaths. And just kind of like seeing that risk benefit calculation play out across population does help some parents sort of understand the perspective of like where the benefit is and why we're encouraging this for kids. But 5 to 11, yeah, we are going to have to see it happen at much larger numbers to see any kind of effect.
Great. And unfortunately, we're still seeing kids get COVID. I'm glad to say it's going down in our region. Can you talk a little bit about the timing? I don't know if we have that again from the study. Do we know the timing from the time they had infection to when they can get the vaccine?
So the children who are enrolled in the study were supposed to be children who didn't have history of disease for the large part. And so I don't think that we're going to have any specific data there. But we know, leveraged off of what we have in adolescents and adults, that you can get vaccine as soon as you're out of, isolation period. It's safe. We are leveraging off of ACIP's, sort of fundamental rule, which is as long as you are not moderately to severely ill at the time, you can get vaccine. We do know from adults that, having recent COVID infection, you may have more reactogenicity with a receipt of the vaccine afterwards, maybe that first dose. So I think that's something important to counsel on. There were original thoughts when we had shortage of vaccine to say you could wait up to potentially 3 months after, because your rate of infection might be lower during that time frame. I don't know that we can truly predict what the future is going to bring with additional variants and other, things that can occur. So I would be remiss by not taking the opportunity to vaccinate a child to provide them that protection.
Okay, thank you. Going to go to one specific adverse effect that I continue to be asked about, and I know I've had other docs talking about this as well, which is, future fertility, menstruation with the vaccine. And you can talk, we're probably talking more the 12 up. Can you help us with that? Because we're still getting that question a lot from families.
Sure. I think, there's no evidence to date to support any concerns about fertility in either males or females. And that's really for any vaccine that we've ever seen. And that also includes COVID vaccine to date. There have been thousands of females who have been part of V-Safe, who have been fully vaccinated and have gotten pregnant. There were females who got the vaccine in the clinical trials and got pregnant even though they were supposed to not get pregnant as part of the clinical trial safety protocol. So I don't have any concerns there. There have been a number of studies. There's some that are continue to be ongoing, looking at sperm count and sperm motility in males after being vaccinated, and found no concerns there. We had a reproductive endocrinologist who we talked to as part of our research committee in our hospital system. And it was interesting. He said, what you should know is that, you get, high grade fever for several days. A couple of months later, you're going to have a decrease in your sperm count. So that would be a deterrent from, getting COVID infection. But no concerns in either male or female fertility. In regards to menstruation, there have been, these reports over social media and things like that. There's not been anything that has been substantiated with data, and NIH has commissioned, I think, five sites. Boston is one, Harvard is another. There are a couple of sites which are going to go forward looking at females and their menstrual behaviors over time to, again, provide that data of, no concern there, but those are ongoing studies. I think those were started, I think that the grants were recently distributed. And so within a year, we should have, all of that data to be able to say, fundamentally, this is not a concern. But I think if you can get pregnant, then likely that speaks to your menstruation.
Yeah, great. I want to ask, and I'll ask both, actually the whole panel, but I've even seen physicians reluctant to give the vaccine out of concern over long-term effects that we don't know about. What would you tell those physicians? And Rebecca, you can start.
Sure. So I would say that when we look at reactogenicity and we look at side effects, we see that those occur temporally associated with the vaccine, and so you're going to see that within that first 2-month period of time. The vaccine is working, nearly immediately to start to provide you that protection, and so we have not seen with any vaccine long-term, side effects. And we have not seen with this vaccine long-term side effects either. So so when you look at that, I think that should allay some fears. If we go all the way back to what feels like forever ago, when the vaccine manufacturers were discussing with FDA, how long do we need to look at safety for, as fast as possible to try to get this available to the public in the midst of this pandemic, based on all of the data that we have for all of the other vaccines we have, we knew that 2 months you were going to see, any side effects that you were going to see. So that's what I would say.
Yeah, and Danny, I mean, you're in public health, and you, I can't imagine you haven't seen this with other vaccines. I mean, how do you? Because a lot of physicians have reached out asking with like partners or people in their practice, that are actually telling families, for their 12 plus not to wait. What would you tell those folks? I mean, in terms of this concern over long-term side effects and waiting.
I think one is reassurance around just the timeline that we've seen effects from vaccination in general, and Rebecca just spoke to that. Two is that, some of that concern really emanated from the mRNA platform and feeling like we haven't seen the impact of vaccines built on the specific platform. And so we often point to the fact that the mRNA platform wasn't created overnight, that this has been built on 20 years of technology that has evolved and that we've seen used in different populations over time without any signal of concerning effects of the platform itself. So I don't know, those are kind of the two thoughts that come to mind immediately.
Okay. I don't know, Christy, if you have anything else you would add to the
outside.
I would
So I got Coco in, so I hope that they bring stuff rather than leaving.
Can somebody find the person?
No, she was barking and I heard a truck and I thought,
if you could, whoever's talking, if you could put on mute, please.
Okay. I would ditto what has been said, but I also, something that is often unknown by the person you see on the street, and not necessarily that they needed to know before now, but the process that this vaccine came to market is the same process every vaccine has gone through, but the time frame was shortened because instead of having every step done in a linear fashion, we had the funding to be able to do some of these steps in parallel. So for example, typically a manufacturer has to raise the money at every single step. And so there takes time between every single step. And then once they even get through the entire process, then they build the plant. And then they have to manufacture the vaccine. So what was happening is that the US government bet that these vaccines would be effective and safe. And they built the plant and processed these vaccines as it was going through the trials, which eliminated a lot of time that typically takes for a vaccine to come to market. And so just reminding the partners in your practice, but also your patients, that this vaccine has not skipped any safety steps. And the timeline that it took to come to market makes sense because of these steps happening due to the way that the US government was able to cover the financial risk that usually the manufacturer has to take on.
Great. And I guess this, I mean, I'll kind of throw this last question that someone's that did put into the chat. And I think this is a concern that's, that how many people do you have to vaccinate to see a reduction in these numbers, and in where, and I think that, and we're seeing that with parents too, right? Most kids are going to do okay, right? With COVID, it's a small number. And so it's that risk benefit I think people are really struggling with, is that how many are we going to have to vaccinate to benefit one child? And I guess if you guys could sort of, in our closing here, sum that up, because I think that is something we're all going to be dealing with the younger kids in particular. Danny, you've already written in the text, so I'm going to make you go first.
Yeah, I mean, I can just recap what I've written here. And I think before I do that, it's just really important to remember that as public health folks, we can have the lens of population data, but for the patient sitting in front of you, like that parent just wants to think about what's the risk to my kid. And so that comparison is just really hard to make. But sometimes it can be reassuring, and especially in this case where I actually do think that is really compelling, right? You vaccinate 1 million people, 60 to 80 cases of myocarditis. So one, just on its head, it is super rare. But two, you know, when you vaccinate 1 million people, you prevent 120 ICU admissions, 6 to 9 deaths, and you think about the reality of what we've experienced here in Virginia, where we've already had 970 or so pediatric hospitalizations and 10 pediatric deaths. And you know, if we could go back in time and have this vaccine at the front end of this, much of that could have been prevented.
Yeah. I know, Rebecca, if you have anything else.
Oh, I'm sorry, I just wanted to jump on that a little bit and just, you know,
Yeah.
I agree. Like as a parent, you go in and stats are great, but what if my kid is the 1 in a million, right? So I think that being empathetic to that is definitely good. You can remind them about the bike helmet, the seat belt, all the things that you do on a daily basis that are the same thing you're doing with the vaccine. You're protecting them. Even you're still letting them ride the bike. You're still letting them go into the car, but you're just providing this safety step to protect that child. And you can also use the stats that this isn't an experiment really in Virginia. We have 64% of 12 to 17-year-olds vaccinated. That's a lot of people. It's not, you know, like this is only a few people have gotten vaccinated. Over 80% of adults have at least 1 dose. This, you can point to the statistics we have in Virginia right now that we have safety and efficacy data to show that this is working, and to give them confidence that this is the safety step they're choosing is just like the other things they're doing in a daily life.
All right, Rebecca, final thoughts for you. Thank you, Christy, too.
So no, I think all of the comments are exactly on point. I also like from Paul Offit, who says there is no risk-free choice. So there is a risk in everything, just like Christy said. What you're providing what we're providing as, you know, the clinicians, and what the parents are providing as the parents, is the very best option to provide safety for the child. And in that, I would 100% say that's vaccine. I would say that's our job, is to protect that child, because you don't know that child may be the one who could have, you know, severe disease. So I think you go in with that, you go in with compassion, you go in with time, and you have an open conversation. And I think that's the most important thing. And you just continue, as we know as pediatricians to do, continue to listen, and then continue to advocate for children. And then just for the question of, you know, this 12 who, you know, is 11 now, I would just say, we'll see what ACIP makes in regards to recommendations on that. I would advocate for get them a first dose as soon as you have it available. If it's available for their age, get it into them. I think that we may have more data on that. You know, do you give them another 10 microgram dose, or do you give them a 30? We may have more data, or we may just have expert opinion where we just say, just give them another 10. But again, 10 looked really good in adults, non-elderly adults. So, and then the rate of myocarditis. So if we look at just overall, I don't think we have it broken down specifically for flu, but overall rates of myocarditis, oh gracious. I don't remember. Danny, do you have an exact number?
I don't know.
In males, it's much higher in, you know, this adolescent population compared to a younger and compared to an older population. I think I don't want to be, you know, say an error.
That's fair. Well, I want to be respectful of everyone's time, to our panelists and to our audience. I want to thank the panelists for making the time to do this. And I know you've already probably worked long days and probably many evenings as well. So thank you for taking the time and answering pediatricians' questions and being here to guide us as we move forward. And what's really exciting, vaccine for the school-age kids, which we're all keeping our fingers crossed that everything's gonna go. We're probably looking, if you guys are, it should be early November, 2nd and 3rd is when that meeting holds. So we're hoping shortly after we'll know if we get EAU or not, right? Does that sound right?
EUA, we should know by October 26th, I think.
Okay.
Be the 27th.
Okay.
We'll see. FDA has been a little slow in the recent few weeks.
Great. Well, thank you, everyone. And thank you to all the pediatricians out there watching. Thank you for everything you're doing. Know that the chapter is thinking of you, and we are working very hard to make sure that you get vaccine if you want to, get it into those kids. And certainly if you have follow-up questions and things, you can reach out to myself, or certainly we can get those questions off to our panelists as well if we can't answer them. All right, everyone. Have a great night, and thank you very much.